Hello, and welcome to this overview of the economic evaluation methods used in healthcare and public health. The aim of this lecture is to introduce you to economic evaluations and the role of uncertainty. The use of economic evaluation is becoming increasingly frequent in the assessment of healthcare technologies worldwide. We will explain the main types of economic evaluation and how to interpret incremental cost effectiveness ratios, as well as the results of simple forms of discounting. The main approaches of sensitivity analysis will also be explained. So at the end of this lecture, you should be able to describe the key types of economic evaluation, calculate, interpret, and apply incremental cost effectiveness ratios, critically assess how healthcare benefits are identified, measured, and valued in cost utility analysis and cost benefit analysis. Analyze the use of quality adjusted life years, QALYs, and different methods for eliciting preferences and monetary values. So there are four main methods of economic evaluation in healthcare and in public health. And each of the evaluation methods assesses the cost and benefits of alternative healthcare interventions. And the main difference between the four methods lies in the way that they deal with health benefits. These methods of economic evaluation of health interventions are cost minimization analysis, cost effectiveness analysis, cost utility analysis, and cost benefits analysis. And the four methods of economic evaluation that are commonly used today for the evaluation of healthcare interventions in health economics have their origins in cost benefit analysis, CBA. CBA was developed over 60 years ago within the framework of welfare economics and to help with public sector investment planning. In the private sector, costs, prices, and profits can be used to guide decisions about private investments, and goods and services provided by the public sector are often provided free at the point of consumption or at substantially below their production costs. CBA was developed as a public sector alternative to private sector profit and loss accounting. So during the 1930s, the first CBAs were carried out in the United States flood control and transport investment programs. And so what is the value of economic evaluation in public health and healthcare? And why is it important? The use of economic evaluation is becoming increasingly frequent in the assessment of healthcare technologies, as we said, throughout the world, where trade-offs are likely between costs and outcomes or between different types of outcomes. The use of economic evaluation techniques can offer a systematic, objective, and value-free means of evaluation. Increasingly, healthcare and public health decision makers are relying on economic evaluation in their day-to-day work. So adopting a comprehensive approach to the identification, measurement, and valuation of costs and benefits aims to ensure value for money from scarce resources. Typically, economic evaluation requires the identification, measurement, and valuation of the costs and benefits of a new technology compared to an old technology. There are four possible outcomes of this comparison. Number one is that both the costs and the benefits are higher for the new healthcare technology. And this means that incremental cost effectiveness analysis needs to be carried out. A second possible outcome is that the costs are lower and health benefits are higher for the new healthcare technology. This means that the new technology is better and is the preferred option. A third outcome is that the costs are lower with reduced health benefits for the new healthcare technology. This means that incremental cost effectiveness analysis needs to be carried out too. And fourthly, we can have a situation where costs are higher and health benefits are lower for the new healthcare technology. Then this technology is definitely inferior and is not the preferred option. So in health economics, costs can be defined and classified in a variety of ways. Unfortunately, economists have sometimes used words in slightly different ways from accountants, which can lead to confusion. So on this slide are the different economic costs that you will find relevant to the identification, measurement, and valuation of costs in any method of economic evaluation. So opportunity cost denotes a concept in which cost is more than simply the money that we spend to obtain something. And it is the opportunities and benefits that we give up to obtain things that are the real costs. And so if we spend money, we must forego all the other things that we might have done with that money and the benefits that we could have consumed. For example, if we convert an empty word into a recreation area, we need to consider that and what other uses that word might have had, and the opportunity cost contrasts with the accounting definition of cost, as accountants are only interested in the amount of money spent during a specific period of time. Marginal cost is the change in extra cost of producing one unit and one more unit of an output, and that is the extra cost of increasing activity by 1 unit. Average cost is the total cost of a good or service and divided by the number of units of output produced. Incremental costs reveal the cost of switching from one treatment option to an alternative treatment option and are sometimes confused with marginal costs in the published literature. In our previous discussions on accounting or budgeting for public health programs, we made a distinction between direct costs as those resources that are used directly in the delivery of the program, such as wages and salaries for staff members, and indirect costs, which are those costs that are not strictly associated with the delivery of the program, but rather with supporting the program, such as utility and telephone bills, legal and human resources staff. In healthcare economic evaluation, there is also a classification of costs into direct and indirect. So direct costs are the resources that are used in designing, implementing, accessing, receiving, and continuing the healthcare intervention being evaluated, and are usually the main focus of a cost analysis. So they are the cost of providing or accessing healthcare services that can be incurred by either the provider or the patient. Both should be included unless the study perspective dictates otherwise. Direct costs can be further classified as direct medical and direct non-medical. Direct medical costs are those costs that are essential to the implementation, the receipt, and continuation of the health services. They are the resources that are spent on healthcare, for example, cost of medications and laboratory investigations. The direct non-medical costs are resources used in connection with the health service, but are not health sector costs. So examples include the costs of transportation to and from the health facility and the cost of catering in the hospitals. Indirect costs are the other resources that might be used as a result of the healthcare intervention and refer to the resources like the patient's time that is taken up and going to the hospital rather than walking. Similarly, other family members may also have to change their work schedules to take over some of the tasks that would have been done by the patient or to accompany the patient to receive care. And so therefore, indirect cost is the value of lost productivity. And indirect costs are commonly measured using lost wages and earnings. If wages and earnings are not available or the person is not working, alternative methods can be used to find the value of their time. Fixed costs do not vary with changes in the level of activity. For example, building and equipment costs and salaries of staff. Variable cost fluctuates with changes in the level of activity, for example, the cost of medications and consumables. Capital cost relates to the purchase of items that can be used for several years. And so these costs are usually incurred at one time point, whereas the benefits accrue over the useful life of the good. Because capital investments for such items as equipment can be used over the duration of a program, the costs of capital expenditures may be spread out over that time period. If we are considering an acute condition that requires the use of a piece of capital equipment, the cost of that equipment will have to reflect the fact that it is expensive to tie up money in the capital equipment for a long time, or alternatively borrow money and repay the interest to finance it. Recurring costs relate to short-term expenses such as salaries, travel costs, purchase of items that can only be used for less than a year, and so on. Some healthcare interventions may themselves cause pain and suffering, such as adverse effects from treatment or anxiety about whether the treatment will be effective. And so there's what is called intangible costs, and these refer to the social and psychic costs of treatments, e.g. pain and stress. The value of pain and suffering is termed an intangible cost. So because measuring intangible cost is a difficult task, most economic evaluations do not calculate them. These costs are very difficult to describe, and techniques are constantly being refined to measure these costs. However, you should bear in mind that intangible costs could be major factors affecting the patient's and society's decision regarding treatment options. Even if intangible costs are not quantified, it is good practice to explicitly record the fact that they exist. So let's talk a little bit about costing methods. In absorption costing, the products or cost objects are charged with all the direct costs, and a share of the overheads is absorbed. So absorption costing does not accumulate or report the costs of activities or processes. In marginal costing, the cost is estimated by dividing the cost into two categories, fixed and variable. Activity-based costing, ABC, is a technique of establishing costs more accurately. Activities needed to produce a certain product or service are viewed as giving rise to cost. And the key aims of the ABC are the accurate identification of product costs through identifying activities and their cost drivers, and assisting management to focus on cost reduction opportunities. Critics of ABC argue that it is too complex and too expensive for firms to implement. As an example, the cost of the activity of registering patients can be assigned to each patient based on the time taken by the staff for the registration. Other factors also influence costs in economic evaluation, like viewpoint and choice of comparator. A key point to consider in any economic evaluation is the perspective from which the study is conducted. That is the group or the groups whose costs we wish to include in the analysis. In general, the societal perspective is considered the most appropriate, as it includes analysis of all the costs and benefits that are incurred by the program or the intervention. However, a decision maker faced with a limited budget has a strong incentive to ignore the societal view and concentrate entirely on the costs that fall within his or her own budget. The perspective chosen may be a crucial determinant of the decision made. For example, a study of therapeutic options for the relief of back pain that restricts the analysis to cost imposed on the health service might conclude that treatment is costly and of limited benefit. And in contrast, the same study adopted from a societal perspective would also incorporate the wider benefits accruing to society, such as a reduction in working days lost and the patient's enhanced ability to undertake activities of daily living. Given this wider perspective, it is highly likely that the cost-benefit ratio identified will be more favorable. In any economic evaluation, choosing appropriate comparators requires a great deal of consideration, as it may fundamentally influence the results of the analysis. The comparator should be the current gold standard treatment or intervention. If not, then an explanation of why it is not the case is required. And where pharmacological interventions are being assessed, scrutiny of the appropriateness of the comparator drug and dosages is necessary. A placebo is not usually an appropriate comparator, and it must be emphasized that a do nothing alternative is not a no cost alternative. So there is often a difference in timing between the investment of health service resources and the associated health gain. In economic evaluation, discounting is used to reflect the fact that a cost or benefit occurring in the future is believed to be less valuable than the same cost or benefit occurring now. In general, we prefer to receive the benefits now and pay cost in the future. Most people who have the choice of either paying a charge of $100 today or in 5 years' time would prefer to pay the charge in 5 years' time. On the other hand, most people would prefer to receive a health improvement today rather than wait for an improvement in 5 years' time. So later always appears so far away and distant in the future. So discounting allows us to compare projects with different time profiles of costs and benefits. For example, costs may occur in the first 3 years, whilst the benefits accrue over a 10-year period. And so discounting allows us to express the future costs and benefits of projects in terms of their value today, as is their present value. We do this by applying a discount rate to all future costs and benefits, and that is any cost or benefits that are incurred beyond an initial 12-month period. In any economic evaluation, it is useful to present costs and benefits undiscounted in the first instance and then use sensitivity analysis, which we'll discuss later, to demonstrate how changing the discount rate can impact on the size of the cost effectiveness ratio. A higher discount reduces the weight of future costs and benefits. So proponents of discounting in regards to health benefits argue that if costs are discounted, then it is illogical not to discount benefits. That is, if benefits are not discounted, then postponing a project becomes very attractive, as the cost will be ever depreciating, yet the level of benefits stays the same. This is another way of saying that only discounting costs has the effect of reducing the impact of such costs and potentially showing interventions to be more cost-effective than they would otherwise appear. The main argument against the discounting of health benefits appears to center around the debate that there is no real evidence to suggest that individuals do value current health states more than future health states. It is relatively easy to accept that $100 spent now is worth more than $100 spent in 5 years' time. But how does one compare a healthy year now to a healthy year in 5 years' time? Also, it is argued that preventative programs are disadvantaged by the discounting of health benefits, as their benefits typically manifest over a long period of time. So let's look at the first method of economic evaluation, cost minimization analysis. And this is an appropriate evaluation method, economic evaluation method, when the case for a clinical intervention has been established and the preventative and diagnostic or therapeutic procedures or programs under consideration are expected to have exactly the same outcome. And indeed, a prerequisite for conducting a CMA is that the healthcare technologies being compared are clinically equivalent. This means that prospective economic evaluation cannot be assumed before the trial results are known. And so CMAs are typically based on the results of randomized controlled trials. In CMA, the least expensive option is preferred. This method of economic evaluation might be appropriate for comparing the cost of day surgery versus inpatient treatment for the repair of hernias, if the clinical outcomes and patient satisfaction are confidently known to be comparable. Another appropriate use of the results of a cost minimization analysis would be a decision to prescribe a generic drug instead of a brand name drug, which should, in theory, achieve the same effect at less cost. So CMA is concerned with technical efficiency, as the consequences of the alternative treatments being compared are equivalent. However, demonstrating that the health outcomes of two different technologies are identical or equivalent can be both time-consuming and complex. And frequently, cost analysis are erroneously labeled as CMAs, that is, costs are estimated without any consideration of whether benefits are similar, which can lead to misinformed decision making. Also, cost minimization studies should not be confused with cost of illness studies, which simply estimates the size of the cost burden to society of a specific disease. Next is cost effectiveness analysis, CEA. This properly refers to an evaluation where the health benefits can be defined and measured in natural units such as years of life saved, number of fully immunized children, and so on. So the health benefits described in a CEA are unidimensional, and cost effectiveness compares therapies whose outcomes can be measured in the same natural units and measures cost in monetary terms. For instance, if the desired outcome is relief of severe reflux esophagitis, consideration might be directed towards estimating the cost per patient relieved of symptoms using a proton pump inhibitor like omeprazole compared to those of using H2 blockers like cimetidine. This method might also be appropriate for comparisons of the cost effectiveness of two or more drugs for the control of HIV infections, where costs are measured in monetary terms and outcomes in terms of the number of HIV infections avoided. CEAs can be performed both within and across clinical specialties as long as a common natural unit of outcome is used. For example, cost per life year gained, cost per operation avoided, cost per fall prevented, cost per life saved, or cost per case detected. So CEA is the most commonly applied form of economic analysis in the health economics literature, that is in the health sector, and is commonly used in drug therapy. It cannot be concluded from a CEA that a healthcare intervention is economically worthwhile, and that is that benefits are greater than cost, because CEA focuses on comparing the cost of different interventions to their health outcomes, but it doesn't inherently consider the societal implications and the budget constraints or broader economic factors that could influence a decision about funding or implementation. So CEA asks the question, how should we do things? And not should we do things, meaning it is similarly concerned with technical efficiency. Until recently, it has been tacitly assumed that when CEA is carried out, it has already been established that the treatment objective is worth meeting. However, current interest in the estimation of a decision maker's willingness to pay for a unit of effectiveness has led to more explicit considerations of worthiness. There are two main criticisms of using CEA. First, all the health effects are assumed to be valued identically, e.g., a life year gain is valued the same for a 4-year-old as it is for an 80-year-old, and 20 life years saved to one person is the same as one life year saved for 20 people. Secondly, it is argued that healthcare interventions are rarely so similar as to be measurable in terms of a single effect. In any CEA, we end up with two or more different cost effectiveness ratios, CERs. The calculation of the incremental cost effectiveness ratio, the ICER, reveals the cost per unit of benefits of moving from one healthcare option to an alternative option. So ICERs are calculated using the formula ICER equal to cost of therapy A minus the cost of therapy B, all divided by effectiveness of therapy A minus effectiveness of therapy B. For example, we could evaluate radiotherapy alone versus chemotherapy for breast cancer. Assuming chemotherapy costs $15,000 and the patient gains 10 years on average, and radiotherapy costs $5,000 in total, and the patient gains 5 years on average, the incremental cost effectiveness ratio will be $15,000 minus $5,000 divided by 10 years minus 5 years, which is equal to $2,000 per life year gained. So whether or not an ICER is acceptable in terms of cost effectiveness is very much dependent on the healthcare technology being evaluated and the aims and objectives of the research. And the question that must be asked is whether or not the ICER is higher or lower than the decision maker is prepared to pay per unit benefit. And this value is known as the decision maker's threshold willingness to pay, or the ceiling ratio, or cost effectiveness threshold. Often information on this value can be found in published health economics literature. If the monetary value of the ICER is similar to other ICERs for widely adopted healthcare technologies in the disease area, then the ICER may be assessed as being acceptable. When more than 2 programs are being compared, some steps can be taken to conduct the cost effectiveness analysis. And the first would be to rank options in terms of decreasing costs, and then you eliminate options for which another option is cheaper and more effective, and this is simple dominance. And then you eliminate options where a combination of 2 options is cheaper and more effective, and otherwise known as extended dominance. And fourthly, you calculate the incremental costs and incremental benefits for each of the remaining options with respect to the previous options on the list. And then finally, you calculate the ICERs for the remaining options. An alternative to ICERs is the net benefit approach. Rather than concentrating on the calculation and comparison of ICERs, the goal of the net benefit approach is to represent the worthiness of the healthcare technology with cost and benefits being expressed in the same outputs. For example, in CEA, the ICER is essentially equal to the change in cost divided by the change in benefits, where the costs are measured in monetary terms and the outcomes are measured in natural units of effectiveness. However, it is useful to express costs and effects in the same units. In order to represent costs and effects in the same units, the net benefit approach is used, and this approach relies on the use of the ceiling ratio, that is the threshold willingness to pay for a unit of effect, to convert effects into the same units as costs, or that is the net monetary benefit, and convert costs into the same units as effects, and the net health benefit. We move over to cost utility analysis, where we'll also be considering the concept of QALYs. So cost utility analysis, CUA, is a form of economic evaluation that focuses particular attention on the quality of the health outcomes caused or avoided by healthcare programs, services, or technologies. CUA can incorporate both the increase in the quantity of life, and that is reduced mortality, and the increase in the quality of life, and that is reduced morbidity. In CUA, health improvements are typically measured in quality adjusted life years, or QALYs. The results of CUAs can be used to compare treatments both within and across different specialties. CUA is useful when the programs that you want to compare have a wide range of outcomes and you want a common unit of outputs for comparison. CUAs and cost effectiveness analysis, CEAs, have some similarities. So a lot of the points discussed under CEA are relevant to the discussion of CUA. It is inappropriate to use CUA when, number one, only the intermediate effectiveness data can be collected. And number two, if effectiveness of data shows that the alternatives have similar outcomes. Thirdly, quality of life is important but cannot be adequately assessed. And fourthly, the extra cost of obtaining and using utility values is judged to be in itself not cost effective. So let us look at how to calculate and interpret cost per QALY ratios. Calculating QALYs requires the collection of disease-specific survival data with and without treatment, and the quality of life weights for health states and with and without treatment. So economists prefer to measure quality of life in terms of utilities. And utilities are values which are assigned to health states on a scale where 0 represents the state of death and 1 represents the state of perfect health. And so utility values simply represent the strength of preferences of individuals for health states. Higher utility values reflect preferred health states. And von Neumann and Morgenstern in 1944 developed the expected utility theory for rational decision making under uncertainty. And the model developed by them is normative. It presents how individuals should make decisions in the face of uncertainty. It is not a behavioral model as it does not describe actual behavior of individuals. And the von Neumann-Morgenstern VNM theory defines cardinal utility under uncertainty, which is different from ordinal utility under uncertainty defined in contemporary microeconomics. So since the demand for healthcare is uncertain, VNM utilities preferences under uncertainty should be measured in order to estimate the quality of life weights. Imagine that a patient is expected to live in health state A for 5 years without treatment, and that the utility value which corresponds to the patient's quality of life in that health state is 0.5. By weighting survival by the utility value, the number of QALYs associated with being in health state A for 5 years can be estimated. In this example, the number of QALYs is 2.5, that is 5 years survival times 0.5 quality of life, which is equal to 2.5 QALYs. However, if the patient receives treatment, he is now expected to live for 10 years in health state B, which has a utility value of 0.7. By weighting the estimated survival by the utility value, the number of QALYs associated with being in health state B for 7 years can be estimated. And in this example, the number of QALYs is 7. That is 10 years survival times 0.7 quality of life, which is 7 QALYs. So therefore, the incremental QALYs gained from treatment of the patient is 7 QALYs minus 2.5 QALYs, which is equal to 4.5 QALYs. So what are the main sources of utility values for health states? And there are 3 main sources of utility values. Number 1 is the judgment of health professionals. And number 2 is the values from published sources such as the EQ5D, the Health Utilities Index 2, and the short form 36. And thirdly, we have values from measurements on a sample of subjects. So often, health professionals are asked to make judgments on behalf of patients. However, patients and health professional measurements of quality of life may not be the same. Where estimates described in the published literature exist, it may be possible to use the quality of life data in an economic evaluation if the patients and settings are appropriate to the health economics questions under study. Both direct and indirect methods can be used to generate utility values from measurements on a sample of subjects. And direct methods examples include visual analog scales. Individuals are asked to indicate by putting a cross on a line how they would rate a predefined health state. The scale generally runs from 0 to 100, and the best health state is at one end of the line, and the worst is at the opposite end of the line. There's also method of time trade-off. Here, individuals are asked to exchange longevity for better health. And for example, the respondents may be given a scenario where they have 10 years to live, and they can either choose to live these 10 years in a given health state, for instance, suffering from severe anxiety, or can trade these 10 years in a given health state for a lower number of years of perfect health. So if on average respondents choose to trade 10 years of severe anxiety for 6 years of perfect health, the state of severe anxiety would be given a utility value of 6 divided by 10, which is equal to 0.6. Thus, 2 years of living with severe anxiety will be measured as 2 times 0.6, which is equal to 1.2 QALYs. An intervention that will restore someone from severe anxiety to perfect health for 2 years would have a QALY gain of 2 minus 1.2, which is equal to 0.8 QALYs. Another direct method is standard gamble. Individuals are asked to exchange their uncertain survival for better health. For example, the respondents may be asked to make a trade-off between the certainty of having ill health for a specified amount of time and a gamble that has two possible alternatives: staying in good health for the same period of time, or death. And for instance, respondents are given a scenario where they have chronic lung disease and are given information about how this would affect their lives. They are given a choice between staying in that health state, and that is having chronic lung disease, or taking a gamble where one possible outcome is perfect health and the other possible outcome is death. Respondents are asked what probability of the better outcome would make them indifferent between remaining in the described health state as chronic lung disease for setting or taking the gamble. And hence, if they are indifferent between the chronic lung and disease state and a gamble with a 0.8 probability of the better outcome, but 0.2 probability of the death outcome, then 0.8 represents the utility of the chronic lung disease health state. Since standard gamble measures choice under uncertainty, it is consistent with the VNM theory. It also has similarities to some real-life choices. For example, choosing whether or not to have risky heart surgery. An issue with standard gamble is that people are generally risk averse. So for some mild illnesses, people would rarely gamble at all. And under the indirect methods, we have things such as generic measures. Generic measures have a broad application across many different healthcare treatments and conditions. The same generic instruments can be used to compare and measure the quality of life of patients with different diseases. For example, patients with heart disease can be compared with patients with lung cancer. Examples of generic measures are the sickness impact profile, the Nottingham health profile, and so on. The dimensions addressed in generic instruments tend to be comprehensive and broad-based. One of the criticisms of generic instruments is that they tend to lack sensitivity. That is, they are unable to adequately distinguish between patients in different health states, or they might not be able to pick up small but significant changes in patient quality of life over time. There's also the disease-specific measures. and these are designed to focus on assessing the impact of specific health and disease states on patients. It's argued that they are more user-friendly as they reduce patient burden and increase acceptability by only focusing on relevant clinical dimensions. And that is, these measures are likely to be able to pick up small but subtle changes in health states over time. And one of the disadvantages of using a disease-specific measure is that if only a few dimensions are specified, then the unexpected effects of treatment might not be captured. Examples of this kind of measures include the arthritis impact measurement scales and the back pain disability questionnaire. Standard gamble and time trade-off do not usually produce the same utility values, so it is worth considering what approach has been used when you are critically appraising an economic evaluation and that has used direct measurements. And with direct measurement, it is important to question the validity of the instrument scores generated. That is, where the respondents appropriate the health state descriptions adequately describe the health states, were all the questions framed in a balanced and neutral way, and is there evidence that the techniques used to elicit evaluations were reliable and valid? There is some debate in the published literature regarding whose values should be used to estimate utility values. And there are three different groups from whom we could directly elicit utility values: patients, general public, community representatives, and clinical experts or healthcare professionals. Again, there are advantages and disadvantages to asking the different groups. Patients, we could ask, would patients be inclined to exaggerate their condition in order to try to attract more investment into treatments to cure their disease? Or will they underestimate the impact of some health states because they are used to being in them? For the general public, might ask, how does a person judge whether or not she or he is sufficiently informed about a health state if he or she does not have the condition? And so the balance between brevity and burden of information is difficult to assess. And the values of the general public are arguably important, as a result of CUAs may be used in public sector and decision making. And when in talking about clinical experts and healthcare professionals, we could ask, do patients and clinical experts always agree about the important determinants of quality of life? Measuring health-related quality of life is a complex and time-consuming task, and there is no gold standard against which to assess the properties of quality of life instruments. However, there are 5 key questions which need to be asked before deciding on the quality of life instruments for the measurement of health-related quality of life. And number 1 is the instrument reliable? Secondly, is the instrument valid? And then, is the instrument sensitive to changes in health? And fourthly, is the instrument appropriate? And fifth, is the instrument practical to administer? In any CUA, we end up with 2 or more different cost-per-QALY ratios. The calculation of the incremental cost-per-QALY ratio reveals the cost per unit of benefits of moving from one healthcare option to an alternative option. Incremental cost-per-QALY ratios are calculated using the formula. Incremental cost-per-QALY ratio equals to the cost of therapy A minus the cost of therapy B, all divided by the QALYs of therapy A minus the QALYs of therapy B. So whether or not a cost-per-QALY ratio is acceptable in terms of cost effectiveness is very much dependent on the healthcare technology being evaluated and the aims and objectives of the research. The question that must be asked is whether or not the incremental ratio is higher or lower than the decision maker is prepared to pay per unit of health benefits. It is often suggested that in the UK, for example, the National Institute for Health and Care Excellence, NICE, has a willingness to pay estimates of the ceiling ratio or threshold of 20,000 to 30,000 pounds per QALY gained. And this means that any healthcare technology which yields an incremental cost per QALY gained of more than 30,000 pounds is unlikely to be recommended by NICE for use in the UK. However, recent research found that this threshold is too high, and because 13,000 pounds of the National Health Service resources added one QALY to the lives of NHS patients. In the United States, the acceptable upper limit for cost per QALY gained is estimated to range from $50,000 to $100,000. So there are arguments against the use of QALYs, and these include that one, QALYs are ageist, and so older people do not have as many years left to live as younger people, and so the elderly lose out via the application of weights to the number of life years gained. And following these arguments, life years gained and disability days avoided are also ageist measures of effectiveness. Some proponents of QALYs argue, so what if QALYs are ageist and the elderly have had their fair innings? And some even argue that QALYs are not ageist enough. Another argument is that QALYs may not measure the full benefits that are received from healthcare. For example, a mother may benefit from her child being treated, as her quality of life might improve from knowing that the health of her child has improved. And QALYs do not take this into account. Thirdly, the derivation of utility values may be incorrect. And the way in which utility values are elicited is always open to criticism, as there is no right or wrong way to elicit valuations. And this is especially relevant when people without the disease are being consulted or hypothetical questions are being asked. Also, in need of consideration is the fact that utility values for a particular health state might change with the expected duration of the condition. For example, suffering a chronic condition for 2 years might be more than twice as bad as suffering the same condition for 1 year. Opponents of QALYs argue that a QALY is not a QALY. The theory underpinning the calculations of QALYs assume that a QALY is a QALY. E.g., for example, a life year gained is valued the same for a 4-year-old as it is for an 80-year-old, and 20 life years saved for one person is the same as 1 life year saved for 20 people. Arguments in favor of the use of QALYs include the use of that the use of QALYs has considerable advantages over most single-dimensional measures. Examples of single-dimensional measures of outcome include mortality or survival. And there's also the argument that QALYs are final measures of outcome. And final measures are usually preferred to intermediate outcomes. And for example, cases treated or the extent to which cholesterol levels are lowered. Also, others would argue that QALYs are better than nothing, and that at least by having them, the relevant issues associated with measuring quality of life can be debated. There's also the question of whether it is better to calculate QALYs rather than attach monetary values to years of life saved and deaths avoided. So there is value in the fact that cost per QALY ratios of different treatments, both across and within specialties, can be compared, and that these ratios can help allocate scarce resources. Other utility metrics that can be used include the disability adjusted life years, DALYs, and this metric can be used to measure the effect of ill health. The measure uses the residual burden of diseases and or injury as an outcome measure. Healthy life years, HYEs, have been used as an alternative to QALYs. Proponents argue that HYEs are more fully representative of individual preferences than QALYs, and it does this without imposing restrictive assumptions as seen with QALYs. There's also the healthy life years, HLYs, and this utility metric combines quantity with quality of life as well as productivity. We'll move over to the cost benefit analysis, CBA, which is the only economic evaluation method where costs and benefits are both measured in monetary values. It is concerned with allocative efficiency. So unlike cost effectiveness analysis where outcomes are measured in natural units, that is life years gained or disability days avoided, cost benefit analysis measures outcomes in dollars, pounds, or euros, as the case may be. In theory, CBA is undertaken from a societal perspective and aims to identify, measure, and value all costs and benefits associated with the healthcare intervention under evaluation, no matter who or which sectors of the economy incur costs and benefits. However, in practice, CBA becomes a very narrow form of economic evaluation because it is often restricted by measurements and valuation problems. It is the most theoretically solid form of economic evaluation as it is based on complex welfare economic theory. It is the most widely used form of economic evaluation in the public sector that is beyond the health sector, and it has a long history in the transportation and environmental sectors. Although it was the first economic evaluation method to be introduced into health economics, it is not one of the forms of economic evaluation most frequently carried out in the health sector currently. So the main strength of CBA is that it helps us to answer the question, is the healthcare intervention program or service worth it? CBA is the only method of economic evaluation that allows us to question the worthiness of an individual project or intervention. That is, individual interventions can be assessed. All other forms of economic evaluation require a comparison of at least two alternatives. CBA is used to determine whether the benefits of an intervention are greater than the cost of an intervention. If the benefits are greater than the costs, and then the intervention is judged to be worthwhile. And imagine that a hip replacement costs the health service $5,000 and produces benefits of $7,000. Subtracting cost from benefits reveals a positive net benefit of $2,000. So the hip replacement is judged to be worthwhile, and intervention should therefore be carried out. And if the intervention costs more than the benefits produced, and that is, there is a negative net benefit, then the intervention should not be carried out. The simple decision rule for cost-benefit analysis is that projects or programs should be introduced or expanded if benefits minus the cost is greater than zero. Second strength of the CBA is that it allows very different healthcare programs to be compared. For example, a smoking cessation program versus a community mental health program. When CBA is used to compare different programs, the projects are ranked according to their cost-benefit ratios. CBA is not restricted to comparing programs within the health sector. It can be used also to inform resource allocation decisions between different sectors of the economy. E.g., healthcare programs can be legitimately compared with non-healthcare programs. Given that there are many determinants of health, including education and policies, housing programs, and environmental projects, this approach is the ideal economic evaluation method to compare interventions from different sectors which impact on health. For example, CBA is often advocated by those involved in health impact assessment. And by valuing cost and benefits in monetary terms, there is a common denominator, and this allows the comparison of interventions both between and across sectors. So we are really certain about all of the components of an economic evaluation. Common contributors to our uncertainty include the effectiveness of the intervention, and the quantities of resources used, the prices we should assign to resources, or the time that patients must take off work. In some settings, there may be no data available, or the data are imprecise, e.g. hospital per diem costs rather than patient-specific cost per day in hospital. And one way of dealing with uncertainty is to recalculate the estimated cost and all the effects using alternative plausible values for uncertain parameters, and consider whether different values would significantly alter the conclusions of the evaluation. And such a process is called a sensitivity analysis, since it addresses the question of how sensitive the results are to the values used. And so the first step in any sensitivity analysis is to identify the parameters which are uncertain, e.g. the average length of stay for a patient with tuberculosis. And the second step is to specify the range over which we think the parameter might vary. And to illustrate, if we use an average length of stay of 80 days for patients with tuberculosis, and we actually believe that this number lies somewhere between 70 and 90 days, then we specify this range of values. We must also specify why we think this range is appropriate. For example, plausible ranges could be supported by evidence from reviews of the clinical literature or from expert clinical opinion. The third step is to recalculate the cost-effectiveness ratios based on combinations of best guess value of 80 days, the most conservative value of 70 days, and the least conservative value of 90 days. And based on the reworked calculations, robustness of the study results may or may not be confirmed. And if there is no change or very little change in the results of the economic evaluation, then you can be quite confident that despite uncertainty around your parameters, study results can be considered robust. However, as there is no guidance to what variation in results is acceptable, and true robustness is very much open to interpretation. Sensitivity analysis can be either one-way or multi-way. One-way sensitivity analysis addresses individual sources of uncertainty, and so estimates of each parameter are varied one at a time in order to investigate the impact on study results. And for example, we might recalculate our cost-effectiveness estimates using a higher nursing wage rate. If nurses only comprise a small proportion of our total cost, even a large difference in wages may have little effect. Although one-way sensitivity analysis is the simplest and most common approach to sensitivity analysis, there exists the risk that interactions between parameters may not be captured. Multi-way sensitivity analysis addresses several sources of uncertainty together, and more sophisticated forms of sensitivity analysis can use assumptions about probability distributions or information about such distributions from data collected in the study. So we have come to the end of the lecture. I hope you can apply some of these concepts in your forum and discussion. Thanks for watching.